Hello, today's topic will be intraventricular conduction delays, which most notably includes bundle branch blocks. At the end of this lecture, you will be able to identify right and left bundle branch blocks and differentiate between complete and incomplete blocks, fascicular blocks, and non-specific intraventricular conduction delay. You will also know the common etiologies for right and left bundle branch blocks. Here is a diagram of the pathways taken and sequence of events as electrical depolarization proceeds through the heart. For the majority of patients in normal sinus rhythm, electrical activity is initiated by pacemaker cells located in the sinus node, alternatively known as the sinoatrial node, or SA node for short. The SA node serves as the normal pacemaker for the heart and is located in the high right atrium near its junction with the superior vena cava. Impulses travel in multiple directions along poorly defined conductive tissue through the atria, triggering atrial depolarization and contraction along the way. When the electrical impulse arrives at the atrioventricular node, or AV node, there is a brief pause on the order of approximately 100 milliseconds, give or take. It is this delay that is responsible for the majority of the PR interval. Once electrical activity has made its way relatively slowly through the AV node, it passes through the His bundle located in the upper intraventricular septum. The His bundle divides into the right and left bundle branches. The right bundle carries electrical impulses to the right ventricle, triggering its depolarization and subsequent contraction. The left bundle is a little more complicated, with some poorly defined fibers branching off and triggering depolarization of the septum. In addition, the left bundle further divides into a posterior fascicle and a less robust anterior fascicle. The posterior fascicle loops both posteriorly, inferiorly, and slightly medially, while the anterior fascicle loops both anteriorly, superiorly, and slightly laterally. Both are normally responsible for depolarization and contraction of the left ventricle. In some circumstances, when the right bundle is non-functional, known as a right bundle branch block, the right ventricle must receive the signal for depolarization from the left ventricle. Since this signal is not transmitted along the same specialized conductive tissues that comprise the bundle branches, depolarization of the right ventricle is slow compared to the left. This results in a wide QRS complex. When the left bundle is blocked, so are the anterior and posterior fascicles, and thus both the septum and the left ventricle must be depolarized slowly via the right ventricle, again resulting in a wide QRS complex. In the situation of a block of the left anterior fascicle, the left ventricle can still be fully depolarized by the conductive tissue of the posterior fascicle. Thus, the QRS complex duration is normal, but as the entire left ventricle is depolarized from an inferior and medial direction, the QRS axis is shifted leftward. The opposite occurs in the relatively rare left posterior fascicular block. That is, the QRS duration is still normal, but now unopposed conduction from the left anterior fascicle results in a rightward axis shift. So what does all of this look like on the actual EKG? Here is a transverse cross-section of the heart with the precordial leads V1 through V6 positioned on the chest wall. We'll first look at the normal sequence of ventricular depolarization. Once the electrical signal has passed through the His bundle, the next event is a left to right wave of depolarization through the interventricular septum. As this is directed towards V1 and away from V6, V1 registers a small positive R wave, while V6 registers a small negative Q wave. Then there is roughly simultaneous waves of depolarization through the right and left ventricles. As the left ventricle is typically more massive, there is more electrical activity directed towards it. Thus, the rest of the QRS complex in V1 is comprised of a large negative S wave, while that in V6 is comprised of a tall positive R wave. In right bundle branch block, there is still first left to right depolarization, resulting in an initial positive deflection of V1. For reasons I cannot explain, V6 in right bundle branch block is often lacking the small Q wave. The next event is unilateral depolarization of just the left ventricle. This is directed towards V6 and away from V1. What happens next is a slow and roundabout depolarization of the right ventricle via the periphery of the left ventricle. This results in a second positive deflection in V1 and a prominent terminal negative deflection in V6. Because depolarization of the right ventricle is inefficient and slow, as it's passing through non-conductive tissue, this final component of the QRS complex tends to be wider than the others, most evident in the wide terminal S wave in V6. Presence of a right bundle branch block is usually most quickly suggested by the overall appearance of the QRS complex in V1, which is sometimes described as M-shaped. Occasionally, trainees will be taught to look for the, quote, bunny ears, referring to the two separate R waves. I've found that using the bunny ears reference actually leads to greater confusion, as a similar pattern of prominent notching can occur in other leads without clinical significance, but which are frequently misinterpreted to be indicative of a major conduction block. In left bundle branch block, there is no left to right septal depolarization anymore. The septum may be depolarized first in a right to left manner, or may be depolarized later. Irrespective, the initial deflections are negative in V1 and positive in V6. There is then fast depolarization of the right ventricle, which is more or less concurrent with a slow depolarization of the left ventricle. The consequence is a deep S wave in V1 and a tall single R wave in V6, which is often notched. Remember that lead V6 points in roughly the same direction as leads 1 and AVL, so that these leads usually show the same changes seen here. You may notice that the appearance of right and left bundle branch blocks can be similar to some other pathologies. So for example, a tall R wave with an inverted T wave in V1 can be helpful in diagnosing right ventricular hypertrophy. Since we can no longer use this finding in a patient with right bundle branch block, its presence severely limits the ability to diagnose RVH. For similar reasons, a left bundle branch block limits the ability to diagnose LVH as well as an ST elevation MI, as left bundle branch block is associated with severe secondary repolarization abnormalities, including marked ST elevations in V1 and V2, as demonstrated here. Are there actual criteria for diagnosing right and left bundle branch blocks? There are, but unfortunately they are not completely standardized. Luckily, the differences between various criteria used by different clinicians are relatively minor. In general, right bundle branch block is diagnosed when the QRS duration is 120 milliseconds or greater, the QRS complex in V1 is M-shaped, and there is a prominent S wave in leads 1 and AVL. Secondary repolarization abnormalities, that is ST depression and or T wave inversion, are usually seen in V1 and V2. Here is an example of a right bundle branch block. You can easily appreciate the abnormal appearance of the QRS complex in V1. The second R wave in V1, usually referred to as R prime, is significantly more prominent than the first R wave. That's typical. You can also appreciate the very wide S wave in 1 and AVL. Typical diagnostic criteria for left bundle branch block includes a QRS duration equal to or greater than 120 milliseconds, a broad R wave in 1 AVL and V6, and a lack of septal Q waves in 1 and V6. As previously stated, there are widespread repolarization abnormalities seen. In leads 1, AVL, and V6, there is usually a downsloping ST depression leading into an inverted T wave. And in leads V1 through V3, there is usually a deep S wave with upsloping ST elevation leading into an upright and prominent T wave. Here is an example of a left bundle branch block with the broad R wave and deeply inverted T waves in 1 AVL and V6. And there is the deep S wave with ST elevation and prominent T wave in V1 and V3. So far, everything I have shown are examples of complete blocks. That is, situations in which conduction down either the right or left bundle is completely disrupted. What exactly is an incomplete block? An incomplete block is an intraventricular conduction abnormality in which conduction is slowed in a bundle but is not completely blocked. It generally manifests as a similar morphology to a complete block, but with a QRS duration of less than 120 milliseconds, usually in the range of 100 to 120. Compared to complete blocks, the etiologies are generally the same, but clinical significance is reduced. Many patients with incomplete blocks will eventually progress to develop complete blocks over the course of many years. What are the etiologies of bundle branch blocks? Right bundle branch blocks can be caused by coronary artery disease, pulmonary hypertension, acute PE, be idiopathic, occur during right-sided cardiac catheterization, or be due to congenital heart disease. Left bundle branch blocks are usually due to acute anterior MI, chronic coronary artery disease, LVH from any cause, or heart failure from any cause. They can also be idiopathic due to hyperkalemia, digoxin toxicity, or unappreciated artificial RV pacing, the last of which isn't truly a left bundle branch block, but which will have an identical appearance to this. Those etiologies which are starred are reversible, and this list is certainly by no means exhaustive. There are two conditions which sometimes come up during discussion of bundle branch blocks. These are names ascribed to largely overlapping syndromes of idiopathic block. First is Lebb's disease. This is sclerosis and calcification of the cardiac skeleton. It manifests predominantly in the aortic and mitral rings and only becomes problematic when that pathologic process begins to extend into the conduction system. Then there also is Lenegre's disease, which is the name given to primary degenerative disease of the conduction system. This presents in younger patients, may be hereditary, and can eventually progress to complete heart block. Next are the fascicular blocks, occasionally referred to as hemiblocks. To understand the EKG changes seen with fascicular blocks, I'll be referring to this diagram, a schematic cross-section of the left ventricle, the classic short-axis view. And here are the approximate locations of the anterior and posterior fascicles within the myocardium. Normally, depolarization spreads circumferentially from both at the same time, such that the net depolarization vector is partially cancelled. In left anterior fascicular block, the myocardium is depolarized solely from an inferoseptal or inferomedial direction, which results in a left axis deviation. Here is what this looks like on EKG. Only the limb leads are shown because the precordial leads are typically not affected by this. Specific criteria for a diagnosis of left anterior fascicular block includes a left axis deviation, usually beyond negative 45 degrees, a small Q wave in the lateral leads of 1 and AVL, a small R wave in the inferior leads 2, 3, and AVF, and an intrinsicoid deflection in AVL that is greater than 45 milliseconds. If you are not familiar with the concept of intrinsicoid deflection, it is discussed in my EKG lecture on chamber enlargement. In left posterior fascicular block, which is much less common, the left ventricular myocardium is depolarized solely from an anterolateral direction, which results in a right axis deviation. Here is an example. Specific diagnostic criteria is largely the converse of that for left anterior fascicular block. There should be right axis deviation, small R wave in leads 1 and AVL, small Q in 2, 3, and AVF, and intrinsicoid deflection in AVF greater than 45 milliseconds. Because all of these findings can also be caused by RVH, there should be no additional evidence of this diagnosis, including a tall R wave in V1 or right atrial enlargement. Another category of block is the obviously named nonspecific intraventricular conduction delay. This is said to occur when the QRS duration is prolonged to 120 milliseconds or greater, but criteria for neither right nor left bundle branch block is met. It is a marker of nonspecific cardiac pathology. Here is a chart summarizing this lecture. When there is a right bundle branch morphology to the QRS complex, that is an M-shaped complex in V1 and prominent S-wave in 1 and AVL, look at the QRS duration. If it is greater or equal to 120 milliseconds, a complete right bundle branch block is present. If the QRS duration is less than 120 milliseconds, the right bundle branch block is incomplete. Alternatively, a complete or an incomplete left bundle branch block is present if there is a broad R wave in 1 AVL and V6, and a lack of septal Q waves in 1 and V6. If the QRS morphology is consistent with neither right nor left bundle branch block, and if the QRS duration is prolonged, a nonspecific intraventricular conduction delay is present. If the QRS duration is normal, then one needs to examine things even more carefully, looking for criteria for either left anterior fascicular block or left posterior fascicular block. If none of this is present on an EKG with a normal QRS duration of less than 120 milliseconds, there is no intraventricular conduction block. That is, intraventricular conduction is normal. There is one final type of block to discuss, bifascicular block. The term bifascicular block is used to describe the situation where a right bundle branch block occurs simultaneously as either a left anterior or left posterior fascicular block. Bifascicular block is most commonly seen in coronary artery disease, but is also well recognized in the degenerative diseases of the conduction system, hypertension, aortic stenosis, and congenital heart disease. Here is an example of a right bundle branch block combined with a left anterior fascicular block. That concludes this lecture on intraventricular conduction delay. Please remember to like or share the video or leave a comment. If you found this lecture useful, you may be interested in subscribing to look at my other lectures on mastering EKGs and a variety of other medical topics.